Hello humans, welcome back to my channel, and this is the first video that I'm making on this channel from my own mental health center. Mm-mm. And it's been about 1.5 years since I became a psychiatrist, and my MD psychiatry exams have been over, and there is just so much to learn, and so much I have learned till now. But surprisingly, a lot of it is not to do with pharmacology or which medications to prescribe. Yes, of course, my knowledge on like what works, what doesn't work, the clinical aspect of things has increased a ton. But more than anything, what has increased or what has just substantially changed is how I see the branch, is how I see my patients, and how when you keep seeing patients in your psychiatry OPD every day, your outlook of looking beyond the diagnosis changes, if only of course you have an open mind for it. And just today I saw a follow-up patient of mine who has been living with OCD, a very young girl, and she has very distressing obsessive thoughts in which she has some very unfortunate thoughts, especially regarding religious figures. And because of that, she has chronically felt a lot of guilt, has she has chronically questioned herself about, is she not a good person, or why is it that she's not able to think about God, think about religion, and pray and do all of those daily activities just like other people of her age can. And there is just so much distress. There was some gap in the treatment. After first and second visit she was doing better, but then there was some miscommunication and she did not get the exact medicines that were prescribed, and now there has been a relapse. And just how distressing that is, not just to the patient but also the family members. We talk about accommodation, which is basically when in OCD, when one person who's living with OCD has symptoms, specific, for example, let's say contamination, dirt and contamination, obsessions, and cleaning compulsions, then the family members may accommodate to to the patient's sort of not demands, but unfortunate needs that they may arise due to OCD. For example, in dirt and contamination, the family members may, just so that the patient doesn't get anxious or angry or irritated, they might start listening to all the demands of washing and cleaning multiple times, just so that the person doesn't get anxious. And this, when we look at it from the CBT angle, can further increase the likelihood of obsessions and compulsions increasing. And you do see accommodation quite frequently in your OPD, which is not something that I was able to experience in my PG days, because during our postgraduates per se, the residents would not usually see a lot of follow up patients, and we wouldn't basically just either be seeing new cases or would see ward workups. And in contrast to what I saw in the government setup versus what I now see in the private setup, it's quite different, the clientele that comes to you. Because in while I was in Harding, we used to see psychosis and schizophrenia spectrum almost on a daily basis, which I do still see now as well. But it would often be an overwhelming majority of patients that I would see, or bipolar affective disorder. But such cases, while very common in private practice as well, you also get to see a lot of OCD, generalized anxiety, depression, and also people who've been going through like difficult life transitions. Um, which is again something that PG doesn't prepare you for, because you see quite hardcore. At least I saw a lot of very difficult to treat cases, and just like the severe aspects of things, just seeing more of severe mental illnesses daily. And therefore, I guess in the beginning of when I started my practice, I did find it a little difficult to be confident in my treatment for common mental illnesses. Even till now, am I more um, confident in treating schizophrenia, or am I more confident in treating OCD? My answer would be schizophrenia. Even though both are very severe mental illnesses, you would expect, and yes, I do see more OCD patients than I see psychosis in my OPD. But I guess the training is such that you see patients for learning during PG, you see patients for case conferences, seminars, for academic studies, and you specifically look out for more difficult to treat cases so that your understanding of psychopathology increases and your understanding of case conceptualization increases. But I guess in that, the you don't really get a good picture of how well or how different things are in private practice, which is then again something private practice teaches you over time. But yeah, it's on 27th of July this year. It's going to be 1 year since I started my mental health center, and not just clinical and not just pharmacological, but there is just so much of clerical work to do. There is just so much of financial things to look at. There is just so much of operational things to look at. Just so many Excel sheets, so many tabs. I There is this one organizational Excel which has about 25 to 30 tabs, all of which are important, all of which are something that are not redundant but are but I do see them on a daily basis. And then there are other Excels as well. um, no one really prepares you for it, definitely. But I did look for where can I find this information. Yes, there's a lot of YouTube resources available, but I found this course on Coursera called the 10,000 Women by, I'm not able to remember the name, I'll put the picture here. And it has sort of helped me get sort of basic picture of what do I need to be looking at, how do I make my expense reports, what do I count as revenue and what do I not, what am I really making money or am I just losing money in this, and just, oh, what direction am I going in, where do I need to cut costs at, and just everything in general, which is just not something which at least medical school or PG training prepares you for. So it's been a journey. And I guess there's just so much that I want to and have to share. Thank you so much for watching, and thank you so much for watching till the end if you've been watching till the end. And see you next time.